Hi, everyone. My name's Mary Dwight. I'm the Senior Vice President of Government Affairs and Community Affairs at the Cystic Fibrosis Foundation, and I'm delighted to be here with this really illustrious panel today to talk about something that we at the CF Foundation spend a lot of time thinking about, value and defining it, and making sure that if we throw patients the lifeline of a game-changing therapy, that they will be able to access it. So I want to do brief introductions. There are more robust bios in your packets, and these bios are impressive, so I encourage you to look at them. But I'm just going to start by giving you a top line of who's here, and then we're going to dive right in. All the way to the left is Sean Tunis, who's currently the president and CEO of the Center for Medical Technology Policy. Sean's been in the space of evaluating therapies for a long time, and is a real leader at CMTP. I always mix them up. I live in DC. I should get my acronyms better than I do. Sean's worked extensively with the Institute of Medicine and was at the Centers for Medicare and Medicaid Services for a long time. Next to him is Reid Tuckson, who is currently the managing director of Tuckson Health Connections. But Reid has been just about everywhere, I think. And I always enjoy listening to him, and he always has little nuggets that stay with you, so we're glad to have him on the panel. He most recently was Chief of Medical Affairs at United Health Group. He's also held positions at the American Medical Association, and also, since I'm a DCite, was Commissioner of Public Health in Washington, D.C. Next to me on the right is Dean Rosen, who currently has two hats, President and CEO of Breakaway Policy Strategies, a health policy, I guess I can call it a think tank, an advisory board in Washington, and also a partner at Melman Vogel Castellani, a health lobbying shop. Dean was a longtime health leader on Capitol Hill, working with Senator Bill Frist on some real pivotal legislation, including HIPAA, the Medicare prescription reform bills, and a long line of other things. So glad to have him here. Next to him is Shami Fineglass. Most importantly, she wants me to tell you that she is a champion BMX racer. And that's why she's here. No. Exactly. Right now, Shami is CEO of the Fineglass Group. She has also been VP for Global Medicine and Regulatory Affairs at the medical device company Zimmer, and also has been at CMS, really at the forefront of setting payment policies. And finally, last but not least, a colleague of ours in the CF community, Greg Alton, who's the Executive Vice President for Corporate and Medical Affairs at Gilead Sciences. And Gilead has an important CF drug, so we always like our friends at Gilead. And he's an accomplished lawyer who's navigated many of these healthcare questions for a long time. So I want to start, Reid and Dean and I are going to try to set the stage for the discussion, and then we're going to dive into the meat. And I want to start by setting the stage with the story of cystic fibrosis, which I think really can be, I say we're sort of at the tip of the spear of this debate in many ways, and certainly is an excellent case study of the question we're evaluating today. So I don't know if you're familiar with the disease, but it's a rare genetic disease that affects about 30,000 people in the US and about 70,000 worldwide. It's a life-threatening disease. When the CF Foundation was established in the 50s, children diagnosed with CF really didn't live to see kindergarten. So it was really a devastating disease that took very young children. And today we've made really great steps in CF thanks to a very robust network of care and coordinated specialty care, and also a lot of new game-changing therapies. The most telling of this is a new drug that was launched in 2012, early in 2012, in a collaboration between the CF Foundation and Vertex Pharmaceuticals, and that drug is called Kalydeco. Kalydeco is the first drug to treat the genetic defect in cystic fibrosis. So rather than a lot of our important therapies that treat the symptoms of the disease, this drug targets what goes wrong in the cell itself because of the genetic mutation in the disease. And to say it's game-changing is really not doing it justice. We've seen patients coming off lung transplant lists. We've seen people being able to live full, rich, productive lives. Folks go to medical school. be able to conceive children when they weren't able before. To say it's nothing short of a miracle for the people who take it is really accurate. But the drug only treats 1,000 people in the US, and the cost of the drug is $309,000 a year. And you would take it 2 pills a day, most likely for the rest of your life. So to me, that's an example of the question that we're grappling with today. Value. Is that right? How do you value such a game changer in taking a disease from life-shortening devastation to being able to live a full and productive life, but at what cost? So with that, I sort of just set the stage, and I think that's why I get to moderate this discussion, is because we think about this a lot. And I did want to turn to Dr. Tuckson to help us think about, you know, in examples like that, of which there are several out in medicine today, but also in a real changing landscape of what we're tackling in healthcare. What's different, and why are we having this conversation today? What's different about it? What's different about the healthcare landscape, even in just the last 3 to 5 years?
So let me maybe just probably reconfirm that which you as a literate and bright audience already understand. And let me also just put as a quick predicate, I have a lot of interests on the innovation side and the wanting things to work very much. But I think my role is in many ways on this panel to be the unwelcome guest at the party. So I'm going to try to serve that role well if I can. I think that what's different, of course, is the twin concerns, number one of cost and the second of quality. We are at that tipping point now. People have been yelling about cost escalation and yelling about it for a long time. We're there. As you know well, there's no way in heck there's going to be any more money in Medicare to pay for escalating costs on the Medicare side. You know that the tax increases cannot possibly get through the political environment that will be sufficient to continue to grow Medicare like it is growing. You know at the state level with Medicaid that states are tapped out completely in their budgets because of Medicaid, and you know that K through 12 education has been kicked to the curb in almost every state in this country because, in large measure, the increasing costs of Medicaid. So do not expect there to be some huge escalation or tolerance of being able to take more in Medicaid. You know that any corporation with global accountabilities cannot possibly pay more for health care. And if they can't, you know that the small business owners who are driving the middle markets of health insurance are adamant when they go to buy health care. The only things they care about is number one, cost, number two, cost, number three, cost, number four, cost. Oh, by the way, there's maybe some quality in there somewhere. It's purely cost driven. So the only place you can get any more money out of the system is the average American's pocket. And the escalation in out-of-pocket costs versus wages looks like that. And I think everyone in this room knows that the wages are not going to go up to compensate for that. We are at that moment where you've got to be concerned. That is happening at a time when complex health assets are already pissed away 50% of the time, not delivered consistent with the best science. So we are wasting what we have. Medicine is complicated with what we have now. So then to bring the story to conclusion on this introduction is, what's different is we're in this fantabulously wonderful world of innovation. Innovation in biotechnology, innovation in sciences, innovation in telehealth, innovation all over the place. And that innovation in medicine, unlike other industries, is not inevitably associated with driving costs down, but in fact unit costs up. And that is now very worrisome as we look at more complicated things into the system, in a system that we already can't afford, that are not necessarily producing value. And so at the end of the day, the new technologies are being brought in at a time of value where we're marrying, number one, value-based reimbursement to the delivery system, where we're saying to the delivery system, no more Mr. Nice Guy, no more fee-for-service. You've got to align your reimbursement with the quality of the outcomes that you produce. We're saying to the patient, no more free ride where you get to get anything you want whenever you want without putting in your money. You're going to have value-based benefits. They're going to say, you've got skin in the game too. So the alignment of value-based reimbursement, value-based health benefits, now with value-based technology assessment. All three of those have got to come together, and that's the world we find ourselves in. We hope that in this new world, what I just said, with higher levels of scrutiny for the outcomes of things, will not have a chilling effect on venture capital, will not have a chilling effect on small businesses going into this world. But know this, if you are trying to run a business of innovation on the old models where you're just going to try to skim, get by, play games, you have no chance of succeeding in this new world. Other than that, it's easy.
No, I'm feeling bright and shiny now. So I also wanted to, frame our discussion a little bit. Thank you, Reed. And I want to turn to you, Dean. We can't have a discussion on healthcare and value in healthcare without looking at the political landscape that we're in healthcare too. And for everything that Reed just outlined on the economics, we certainly have a whole lot of mudslinging on the political side around the Affordable Care Act and Obamacare. And I would argue that perhaps it hasn't been just a calm and measured debate on this. Yeah. So what do we need to take away from that? How can we peel back the clutter and the mudslinging, and what do we really need to understand about the new landscape in healthcare delivery given the policies that are coming online now?
Great. Well, I'm not sure in the hour we have we can peel back the mudslinging very much in Washington, but I do want to just say very much I appreciate the invitation to be here, and it's been a great couple of days, and this is a great panel. I spend kind of my career, and I've been in Washington now doing healthcare policy for a couple of decades, and I spend a lot of my time trying to interpret how that policy landscape is impacting some of the business decisions around health that Reed touched on. And I want to say just a couple things I think that underscore the points that Reed made and sort of bring policy into it, because certainly after the Affordable Care Act, we know the government's the biggest payer of healthcare that we have. And I've spent times when you sort of see the scale, and sometimes they are in tension between innovation. Remember a decade ago we had a lot of FDA reforms to try to move things through the process as quickly as we can. We have the PDUFA, MEDUFMA reauthorizations every couple of years where we have this debate, and I see a lot of those in the audience who are caught up in that. But at the same time, there is this overwhelming question about costs, and I think for the last few years, what I've seen is sort of this dichotomy between things like Kaleido and all the tremendous innovation that we're seeing represented by folks on the panel today and a lot of you here in the audience, and at the same time, enormously rapid changes in the delivery of healthcare, not just in the innovative products and treatments, but in the delivery of healthcare itself. And a lot of the trends that Reed talked about now accelerated by the policy, and I want to talk about those for just a second as the backdrop, because I think they are now inextricable, and you can't talk about what happens in the private sector divorced from the policy or the public affairs climate. The first is there is this sort of overwhelming interest among policymakers in cost containment, however you say that. And every person in Washington, from the senior most member of the Senate Finance Committee to the junior backbencher who just gets elected to Congress, knows that chart from the Congressional Budget Office that shows over time the Medicare and Medicaid costs are growing faster than any other piece of the budget. As Reed talked about, not just at the federal level, but at the state level, and crowding out, in some cases, other expenditures, in fact, growing faster than Social Security because of healthcare costs going up. And while we saw a slowdown in the last couple of years, the results from the last quarter of last year show that health spending appears to be growing, and we've got a brand new $1 trillion entitlement in the Affordable Care Act, which is going to increase utilization as those subsidies start to flow through the system. So cost concerns are really paramount, and sometimes and folks are looking for solutions. The second thing I want to say is that despite this mudslinging, and you'd think in Washington that the Affordable Care Act and Obamacare are two different laws, because Republicans are from Mars and Democrats are from Venus, and they clearly are talking to two different audiences. And in fact, this election, this midterm election, is going to be about turning out respective bases, and so Republicans and Democrats are very much talking to different audiences to try to do that. It's MSNBC and Fox, but as they're doing that, what's striking to me is that against all of this partisan backdrop over the Affordable Care Act, the leaders in Congress this year of the key congressional committees came together on a bill that hasn't passed, and I don't think will pass this year, but is remarkable in terms of reforming the way we pay physicians in Medicare. And what is that bill based on? It's based on accelerating all the trends that Reed talked about in the private sector, paying physicians in Medicare based on value. So you had the most liberal, Democrat, the most conservative Republican, House and Senate come together around the policy solution, and they can't find a way to pay for it. That's controversial. But against all this mudslinging over the ACA, they came together. And if you look at just what that law, that proposed bill says, it moves things forward. And it's accelerating this trend that as the ACA was so controversial around the insurance reforms and the website and the coverage details, but a lot of what's happening that was authorized by the Affordable Care Act in terms of the Centers for Medicare and Medicaid Innovation, experiments with alternative payment models, greater use of how do we pay for things based on value, has a lot of support. Now, there's a lot of concern about it, which is what we're going to talk about today, which is, do those measures and do those metrics adequately account not only for cost, but also for value, and how does that value measured over time, and does it take into the view multiple stakeholders, not just the payers, but also the patients and the innovators? That's a question. The last thing I want to say, just to set the stage, is that the other thing that's happening that's, I think, putting a finer point on it is, as we move from the story of the kind of core of the Affordable Care Act of, did people get signed up in this, kind of crummy rollout with the exchange? When you're on Saturday Night Live that things aren't going well. But people are going to start to look at the coverage that's available that they get right now. And they started to look at the premiums. But when you look at the coverage under the Affordable Care Act, there's relatively high cost sharing. There's relatively high deductibles. Clearly, there's a lot of limitations on things like specialty tier for drugs, deductibles that apply to drugs and devices that we don't see in the commercial market. And why is that? It's because against this backdrop, the law put in place a whole series of regulatory requirements, actuarial value, essential health benefits, and other things that plans are trying to balance, as Reed would have been doing in his old job. How do we make the most affordable premium, but still, get people this coverage? And so we're going to see those trends, and payers now being even more focused, like a laser on, is what I'm going to cover valuable? And even if I'm going to cover it, how am I going to cover it? And what kinds of cost sharing might I put in place? So let me stop there.
Thank you.
Thanks.
I think you guys both framed us up well, which is really, it's a story about costs, and that's true for public payers and private payers. The squeeze is on. And so in the face of that, and in the face of all this amazing innovation that's going on in healthcare, I mean, it is such an exciting time. We have to figure out, I'm going to use your phrase, Reese, because I love it. How do we cut the crap out and pay for what really works? And I think what I'd love to get into today is, how do we determine if it really works? And so, Greg, I want to turn to you. And I would say one thing we see in the cystic fibrosis landscape is that no longer is regulatory approval a green light for the market. And that we see that we can have great results and you can meet your endpoints to the FDA and off you go and you've gotten approved, but then there's this whole other landscape that you have to navigate to be sure that the patients are getting their therapies. And obviously you've been sitting here navigating this for some time. I'm not sure if you all are aware, but Greg's been navigating a brand new hepatitis C treatment that's received an awful lot of coverage for its efficacy and also for its cost, and has really been a linchpin for this discussion. So I would love to have you talk a little bit about how you guys see value and how you define it, and what are the terms you think about when you're thinking about not only bringing a drug through the development and discovery process, but then how are you factoring in these questions of value beyond regulatory approval?
Happy to answer that question, because yes, I've been thinking about this a lot. And you said that with Kalydeco and Vertex that you've been at the tip of the spear, and I've heard that comment directed towards me at least 3 or 4 times in the last couple weeks, that Sovaldi, which is the hepatitis C drug that Mary's talking about, has really generated a lot of discussion around the cost of specialty care and cures.
Yeah, we can hand the spear over to you.
So you can. I'd prefer you be on the tip of the spear personally, but we can share that honor. So just a little bit about Sovaldi, just to put it in context. So it's a cure for hepatitis C. So this is not a chronic treatment. It cures hepatitis C in about 3 months. And in terms of cost, we charge $84,000 for that 3 months of therapy. In terms of how we came up with the value, and I completely agree with the other panelists in terms of 100%
effective, right? Which is really critical.
It's close to 100% effective, yes.
Huge amount of patients.
Huge amounts of patients, and I won't go into the detail on it, but we have research that's going to get even better. What's happening? So when we priced the product, we looked at the prior therapies, which were pretty lousy. They had lower cure rates. They were very toxic. Most patients couldn't tolerate them. Those who could tolerate them went through a brutal 24 to 48 weeks of incredibly difficult therapy. So the prior therapies, what we hear is, were fairly self-limiting due to their toxicities. And this is going to relate to something that Reed mentioned earlier. So in terms of our pricing, we priced it basically the same as the older therapies. Although on a per cure basis, it's actually much more cost effective because we have a higher cure rate. So you get more value just based on that. You cure more people for the same amount of money. We also look at total treatment cost, not just drug cost. So I think this is something that I think our system doesn't do a very good job of. People look at drug costs, but actual treating people with the older therapies would cost another 50% more because you're having to manage the side effects. And not just from counseling the patients, but also using, the patients get anemia. They would sometimes need blood transfusions. They would sometimes need epogen. So the total treatment cost would actually get up to $150,000. And I think at Cedars-Sinai, they actually said, close to $200,000 was what they were looking at. Now that would vary depending on your patient population. So we're actually reducing the cost of curing somebody significantly with the new therapy. We also looked at this compared to chronic care. What do we pay for drugs like for multiple sclerosis, or what do we pay for rheumatoid arthritis? Gilead's very familiar with HIV. We make the leading HIV products as well. What do we pay chronic care for HIV? And if you net present value the chronic care drugs that we use quite often, this compares very favorably to those drugs because you take those for life, and this is a total treatment cost. We look at this as total treatment cost, and that's what the $84,000 is. That being said, what's happened is, and this is why I think there's been a lot of attention on this, and this goes to Reed's point, we weren't paying for this before. This was not something we were paying for because we couldn't. And we've now we have new innovation where we could go from treating a very small percentage of hepatitis C patients to literally everybody now could be treated for hepatitis C. And so the payers are saying, I didn't plan for this. This is not something that I budgeted for. And so that's put a huge strain currently on the system. And that's where a lot of the controversy is, even though it's less expensive, et cetera. In terms of total cost, we also look at the cost of not treating hepatitis C. And if you don't treat hepatitis C, about 30 to 40% of those patients will develop cirrhosis, liver cancer, they'll need liver transplants, and those are very expensive patients for our healthcare system. But what's interesting about this debate right now is that those are future costs. Those are costs that will hit 5, 10, 15 years from now. So as we're having this conversation about cost savings to a system, it's an upfront payment today to cure people to prevent costs that are down the road. And that is a very difficult concept for our healthcare system to absorb. We like chronic care. We're accustomed to that. We're not used to making the investment today.
So can I follow up with you on that? And I want to read you a quote from the New England Journal of Medicine on the Solviday. It said, "Cost alone cast a pall over the stunning success in achieving the long hoped for goal of a safe and effective therapy for hepatitis C." So there's the docs saying, we know this works and what a game changer, but how do we factor it in, to your point? And I know you guys have been navigating in various states, here in California, Arkansas, where the Medicaid director said, you know what, we're not going to pay for it now unless we're going to pay for the very sickest. Those who don't have symptoms must wait. What is the response to that? Is it purely budget? Is it purely that a little state like Arkansas, which I would add is also not paying for all Kalydeco patients, is it purely that they haven't factored in the cost and we're surprised? Or, what is, and I definitely want to bring the payers into this too, so you guys should jump in, Shami, Reed, do we set a new landscape in budget? Is that really it?
So I think a couple of things. I think be careful of reading the media and getting your facts from the media. So the fact is actually patients are getting the drug. So we treated more people in the first quarter this year than have ever been treated and cured in a quarter ever. So I think that there's a positive side to what's happening out there. And that's for all payer segments. We're seeing patients in private, we're seeing patients in Medicare, managed Medicare, and Medicaid receiving the drug. Is there triage ongoing? Yes, there is. And this is from what I said, that, and when we talked to the Medicaid, they did not ask the states for the money. They didn't see the volumes coming. It's not the cost of the drug. It's the number of patients that are now saying, I can now be treated, I want to be treated, where before that didn't happen. So I think there will be a natural adjustment for that. But the question, I think, coming back to Reed's point, how much is our system willing to spend up front to cure a disease where the costs are down the road? That is the bigger question.
Well, it's also that, but and I think your analysis is great. It's also that, but it's also just trying to do the math. If look at who are the folk with this disease, overwhelmingly they're public insured people, or to a huge amount anyway. So this is a state that is saying, okay, I get the value-based stuff, and that was a very articulate thing, and I think I like the way you came to that. I get the value-based of not treating. I get all those, everything you said. At the end of the day, my citizens said no more taxes. So now, let's see. I've got this wonderful thing. By the way, there's this other wonderful thing. And there's this other new thing. And we don't have the money for it. So we now open up two things that have to occur simultaneously. Number one is anybody that is administering health benefits on behalf of a state or a private company, you had better make damn well sure that only the people that are supposed to get this thing get it. You better make damn well sure that the providers who are giving it out are doing it appropriately with evidence-based guidance. You better make sure that there's every management control you can think of to not let one penny of waste go. And that's going to be real hardball and inconvenient to everybody in the system. But the second thing is that we're getting very close, if we're not there now, to this R word. So this rationing word is now, we're close to as a society realizing that guess what? The math just don't work. And so you got to decide who gets what and how much. And if you don't like that conversation, then you have to be the first ones that are prepared to say more taxes.
And I think it's not that we're about to get to the rationing point. I think we're there. And I think what's interesting is you have a drug that actually is quite innovative, a game changer, really, we think, does what it says it does. And there's this notion of innovation for innovation's sake, or I never thought I'd be quoting will.i.am, but I was at his session and he says disruption for disruption, innovation for innovation doesn't make sense to him either, which I thought was fascinating. But here you've got something that is true innovation. So besides getting to rationing, money, how are you going to pay for this, is the point of what do you do with true innovation? How do you define that value versus something that's perhaps a line extension or something that may help a smaller population but doesn't really help them that much. And so part of the issue with, and I come from the device space, I also know drug space a little bit as well, and the issue there is some of these things fuel the financial engine of the company so they can get to these true innovations. But it comes back to what Reed is saying of, well, what can you pay for? Where's the bottom line for that money? So it's really almost as if you have to have focused innovation, focused disruption of the hep C market, actually, and figure out who's going to get it. The rationing thing is frightening to me from the standpoint of it's going to come down to, at some level, socioeconomic status, which to me is the travesty of this. Besides the fact that the states may not be able to afford it, probably guarantee you that someone can figure out how to pay for it if they have the means to pay for it, but there's a huge population, in this case that have hep C, that don't have the money to pay for this.
So I wanted to just offer a couple of thoughts. First of all, this piece of the conversation can go on for a long time. I think it's very valuable. I think the Kaleido and the Sovaldi examples are kind of one, in a sense, unique aspect of the whole, how can we better pay for value? No alternative therapy, they have life-changing health impacts, and then the question is, how do you set a fair price for something like that when basically people are going to have to get it? There's no way you can say, well, we're not going to pay for it, it's too expensive. It's really a question of what's a fair price and how are we going to be able to afford it and what else are we not going to pay for. The place that I think we also need to think about, which is somewhat separate, is I don't know, sort of the more mundane opportunities to improve the value of care with, sort of standard technologies. And Reid, you made the point that, there's no more money in the system, it's going to have to come from the patients. But I really think the business opportunity, the investment opportunity for innovation is taking costs out of the current system.
Exactly right.
Right?
Which exactly right. Cut the crap out.
And finding cheaper ways to actually treat things that are now treated more expensively. And I just wanted to I'll try to tell it fast, but it's a war story from CMS. So, and it had to do with implantable defibrillators, which people know I think are for preventing sudden cardiac death. Shami, you may have worked on this with us.
I was about to say, was I involved in this?
You may have been.
I
But
think I was.
the issue was there came out a study that showed that actually they reduced mortality by about 30% in patients who'd never had a previous episode of a cardiac arrhythmia. So basically, preventive use of implantable defibrillators, and they're about $35,000 to $50,000 each. And there's millions of Medicare beneficiaries who kind of fit the criteria all of a sudden. So this was going to be a new sort of $2 to $3 to $5 billion annual spending line for Medicare. So we had a lot of conversations about this. And what was an interest, very stuck in my head was, it turns out that there are such a thing as what are called, airbag or Volkswagen defibrillators. All they do is deliver a shock, and they're about $10,000. And they actually are perfectly adequate for this large group of patients who are at risk for sudden cardiac death. So, I asked the cardiologist that I dealt with, why wouldn't you choose to put in a $10,000 defibrillator, which is perfectly fine for this patient, rather than a $35,000 one that has all these pacing and monitoring and all these fancy, and basically they said, well, there's nothing in it for us. We put in the $35,000 one. If we put in the $10,000 one, we don't get any of the savings. The hospital absorbs the savings. And we just rather have a device in there that has, more features just in case we need them sometime. I think the point is that is a past, bygone, prehistoric era. That's not that, and that was just 6 years ago. Well, the reality now is if somebody comes out with a $10,000 version of something that otherwise costs $35,000 in the new payment system, that's the kind of thing that's going to sell, and it's going to make you a lot of money because you come up with stuff like that, the payers will be falling over themselves to pay for it.
So Sean, I'd love to have you and Shami probably jump in on this too, to talk a little bit more on that trend. You guys spend a lot of your time evaluating and determining how to evaluate what's out there now. How do we improve what our toolbox is today? Let's set the game changers aside. I think that's a good way to take the discussion. We did an analysis with a snapshot of 5 cystic fibrosis care centers. And for those of you who don't know, almost every patient in the U.S. gets their CF care at an accredited nationwide center. There are 118 across the country. They're academic medical centers. They're sort of everything you need to treat your CF, which is a complex disease, in one place. And we measure just about everything we can. We have a long-standing registry that tracks the data of treatment that happens at these centers. We can tell you what kind of antibiotics people are on, how many times they're in the hospital, how many times they had lung exacerbations, what their weight is. It's a really rich tool. So we took 5 centers that had the same outcomes. In other words, their patients were all doing about the same on some key measurements. And we looked at how much their treatments were costing the patients. And we saw these vast differences, across 5 centers, all doing the same, all getting the same results. And it boiled down to some simple stuff. Like one of them, their antibiotics costs were double because they'd been throwing the book at these patients when they got a lung infection. And their counterpart that had the exact same end result had been using 1 antibiotic. And I'm sure it was Caistin, I'm sure. But there to me is such an example. How do we use the data that we have at hand to answer the questions that, to get the crap out, to decide what really works, and to move, in your defibrillator example, and to move forward? Can you talk a little bit about some of the discussions going on and some of the tools that are out there to have these kind of conversations?
Yeah, so just picking up from where you started, one of the, important and, and very valuable things that the cystic fibrosis community has done for, I think, 25 years, is create this data infrastructure that is kind of unparalleled, I think, for any other disease, right, where every center submits standardized data, and it allows you to have those kinds of findings almost, you know, free of charge. You're collecting the data anyway, and you can get that kind of information. If you really wanted to launch a study and look at, you know, 2 antibiotics versus 1 antibiotics in a prospective randomized study and, you know, look at outcomes, you know, that would cost hundreds of times more than what you get that information for. So I guess the reason I'm saying that is I think we're in a, you know, the beginning of a transition from payers particularly thinking only about, you know, that truth can only be derived from a randomized controlled trial, to recognizing that there's a lot of more efficient ways to learning, you know, what works and how to practice in ways that improve outcomes and lower costs. So the question is, you know, it works in CF. What I think there's a lot of federal investment now going into actually building analogous infrastructure around other disease areas and through other centers where electronic medical record data, administrative data, laboratory data will all be routinely collected and provide that kind of information.
And then shared.
Yeah.
And the issue there is that it has to be shared among the community. And what you have in the CF community, and I actually know it well from where I trained, is that those are centers of excellence. And those people are all collaborative, even though they're at different sites, and they actually look at the different data, and they can make changes. So some of this is how is medicine practiced. So part of it is how do payers evaluate it and decide what to do, and then it's also how do physicians actually practice? Are there guidelines? Is there some shared experience they can look at? And the notion of registries or other data sets that you can use instead of clinical trials that are robust enough to make these decisions so you can move forward, potentially, as Reed would say, cutting the crap out of what's there, making it leaner, making it easier to treat these patients for less money is exactly what you want to look for. But it takes collaboration.
Yeah. Greg, I would love to get your thinking as a manufacturer, a drug manufacturer, you know, and elaborate on the thesis I threw out there of regulatory approval is not a green light to the market. How are you guys incorporating and thinking about some of the measurements that Sean and Shami just talked about in terms of once it's out in clinical practice, in patients? How can you keep, or can you, as a company, can you keep measuring and refining?
Yeah, so you're absolutely right. Regulatory approval is not a green light to the market. When we construct our pivotal clinical trials, we're looking primarily at safety and efficacy of the drug. We're not primarily looking at cost effectiveness. We're not primarily looking at the benefits long term to a healthcare system. But we do, as we move forward, typically sometimes before approval, but after approval, we start those studies and we start to look at other factors such as cost savings of treatment costs, cost savings of avoiding complications, preventing disease. We look at a variety of those types of factors, and including the R word. I mean, and I think people talk about rationing, and there's like some negative words out there, but I think I forget which panel said we're already there. We've been there for a long time. It's just so there's a lot of disease out there, and cystic fibrosis is one of them. That you don't throw all the antibiotics at somebody on their initial diagnosis. And the same goes for HIV. That's always been the case for HIV. There's always been a debate about when to start therapy and who to start therapy and what to use initially. And that's a debate that has to occur with the medical community, but also needs to involve the payers. And I think so it's not just can't just be driven by what's the medically appropriate thing to do. There has to be cost factors that factor into that, and that's going to happen with hepatitis C.
Right.
And that's okay. And I think that's something that has to happen. We need to have a real conversation about we don't have an unlimited budget here, and we can't discount our way out of this out of the volumes. The volumes are going to be there. How are we going to triage the patients through? What's the both medically right thing to do? And what can the payers handle? And what kind of financing systems can we look at?
Dean, is there a willingness to have that discussion? Do you think if we look at the macro level, it's because I think the policymakers have to be involved in some level in this discussion. Is there an ability to have this kind of discussion?
I think there is. I mean, I'm always scared about when the policymakers make those kinds of decisions, and I think what really is happening, though, is that the policymakers are setting the framework in which the decisions are made, and want to maybe answer your question indirectly by saying I think what's really important to keep in mind is that, and I think you've seen over the last few years, the quality measures become increasingly important. I think they will become increasingly important as these decisions are made. And we're sort of moved from an era of paying people for just reporting quality, then to paying people for quality performance, then to sort of shared savings. And I think where we're going in a lot of areas now around specialties are bundled payments or full capitation, where the providers, to Sean's example, are now increasingly going to be at risk. And so the question as you move to those models is, how do they value the Sovaldi's when they're going to get paid the same amount, and then there's this innovative but maybe more expensive treatment that comes along, and in this population, can the people kind of get by for a while on some of the less expensive ones? So I think that I want to just underscore, I think they can, but what's really important, particularly innovator community and patient community, is to be involved in developing these metrics and to understand that A, they're imperfect, and B, we're moving rapidly to a system where the parameters that are being set in part by policymakers and in part by private payers are going to govern a lot of these decisions.
Yeah, I think we got three big balls in the air here. First is, from talking to the Congress, and when you talk to the Congress, not in the testimony, but in small rooms and retreats and where they are, be very clear. They have no interest or willingness or ability to start to think about this notion of value and people being denied anything. So for them, it's all magical. It's magic. It all happens by magic.
Can I say one thing, Reed? I think that's why, not to interrupt you, but it's why when you see the consensus around the things like this Medicare physician payment bill, which is what can they get consensus around? We need more value, we need more cost effectiveness. Let's have the provider community come up with these things that are very off in the future, and that's how they deal with it.
But they don't want to deal, and that's where they will stay. And so don't just know that they're, and again, it's easy to make political points when you tried to kill grandma. Right? I mean, that's the easiest thing in the world, and just know that people will revert to the mean when the pressure is on. The other thing is, just imagine the wheelchairs rolling into Congress for the testimony. Public institutions cannot have, so it will always be this ugly fight. Number two, I think this is a very important point around how you do your research. The things that are coming forward now have to anticipate that FDA approval is a necessary but not sufficient goal. And so that we've got to find ways for the innovator community to have a goal to shoot for that's beyond FDA and start from the beginning to try to get there. That's why Sean's work is so very important, because what Sean's organization is all about is trying to find some kind of a consensus around what is that goal. My new hip articulation thing gives you 7.5% more hip articulation. Am I happy, or am I, so what?
Right.
How do I, so somebody's got to know. So once you get through the FDA, so you can't have a glide path where people like you are spending $1 zillion to get to FDA, stop, take a breath, okay, more funding. You got to streamline that some kind of way. Third is the reimbursement goal thing we have up here is this example that you give around the centers of excellence defined, having that much spread in their performance is scary. So do you want the people that pay for healthcare to try to micromanage all of that? Or do you basically say, you know what, we're going to take all the emotionality out of this thing. There's only going to be 3 centers of excellence that are going to participate going forward, and it's going to be those that have the ability to demonstrate. And if you can't demonstrate it, then you're going to suffer economically as a delivery system for that. It's up to you to figure out how do you do it and which drugs you use and how do you use it, but it's up to them. But I think you're going to see a real tightening down on this thing, which I call my opening comments about value-based reimbursement for the delivery system. It's going to get hardcore, except in those places in rural America where there are no options for therapeutic choices of where you go for care.
And then we're going to have some interesting discussions on Capitol Hill when we're closing centers of excellence in
their districts.
In their districts.
You know, to follow on Reed's point, when you look from an investment standpoint on how drugs and devices are developed, and there's a new product development pathway, and you know, the point is, as you know, just because you get something approved by FDA, it says it does what the company thinks it does. And from the payer standpoint, we would then look at it and say, okay, so what? Is it clinically relevant? And having been on the device side, you have to convince people to look at that whole continuum. At day zero, when you're contemplating what on earth you're going to make, you have several hurdles along the way. Are you going to have the data that will support what you say you're doing is clinically relevant? Do you have buy-in from the societies? Do you have the entire pathway? It's not just one hurdle. And that, from an investment community standpoint, is an important point, because as you're looking to make investments in these different types of verticals, you have to be able to figure out, well, what's that real price? How much do I have to put in to develop that thing? Is it going to be worth it in the end? Because can I accept the current payment rate? Or am I going to do the value play from a cost value standpoint, which is, as Sean said about the defibrillators, am I going to invent the $10,000 thing in the $40,000 thing market and thereby obliterate my competition, meanwhile having the same outcomes? So I'm not worse, I may not be better, but if I'm exactly the same and I'm a lot cheaper, that is a huge play from a company standpoint. People are not quite willing to take that yet. There are some companies that are moving in that way. But from an investment community, which many people are in this room, that's the timeline, that's the development cycle that you have to look at. It's not just, we got FDA approval.
Greg, I'd love for you to just comment on what Shami just said, what you're thinking. Do you agree?
Yeah, I do, and I think there's what's motivating business, you know, and development. I mean, I'm thinking about, you know, coming back to what Reed said on cost and new cost to the system, and so if we're looking at developing, you know, so from an industry perspective, what we really are focused on is drugs that treat diseases that are not currently treatable. That's our big focus. That's what we want to do, and I think that's what society wants. But if by delivering those drugs where a disease there was no cost before, we're raising the cost. And what is the message to us as a business when that happens? If I mean, are we going to raise taxes? Are we going to reallocate funds, or how will that get paid for? What's the message to us?
Well, one thing, by the way, I just got to say it, though, just even though it's not the focus of this, and just say it because somebody's going to say it. We didn't say it if we don't say it, so I'm going to say it.
Say it, Reed.
Prevention. So for those things like Hep C, where again, and so now there's a whole different argument that says, all right, at the state level, at the federal level, I mean, are we prepared to put the money in on the real front end that says, wait a minute, we got to turn the spigot off of all these gosh dang on hepatitis C people. So let's get really good at that. And by the way, there is a huge opportunity, again, economically, for innovation in that space. Having said that, with the doom and gloom of the other stuff we're saying, I thought your point is very important. Let's, at the end of the day, and Sean said it, this still is a $3 trillion industry now. I mean,
Right.
no, so even though we're trying to cut, it's not a doom and gloom story. There is room to make money in this space if you can do the things that you just said.
So I want to build on that, because I often think of that there are two debates, and one is a preventative debate, and you could argue you could do prevention for anything, including a genetic disease like CF, but there is a different, you have to look at it differently in my mind, for complex chronic care. Do you know, how do we evaluate A versus B? And you know, your old company is doing some real innovative things around planning and coordination in cancer care and a couple other places. I think Aetna's doing some interesting things around paying for palliative care. You know, in other words, expanding when we're looking at chronic care management, expanding our definition of what that is. And that's something you guys have been working on a lot too, I think, Sean. And so I'd love for you guys to talk about, is there the temperature, the appetite to expand what we pay for? You know, I loved your example of, you know, the business model of undercutting, you know, something that's just as effective. You know, how does that look as a business landscape to folks?
So just to be clear, the question is whether payers are becoming more inclined to pay for services that have to do with more efficiently managing chronic disease.
Yes.
Yeah, you know, again, I think to go along with everything folks are saying is the pressure is finally there to find whatever mechanisms possible to get good outcomes at the lowest possible price. And so things that have not historically been paid for, like care management services or telemedicine or a whole bunch of things that just haven't, particularly in the Medicare program, historically been benefits. You know, that is all in the process of shifting. And again, it's just driven by the, by the cost trends. So, you know, in Medicare at least, there's just a lot of legacy statutory and regulatory language that prevents them from, for example, you know, paying for preventive services, although now, you know, they changed that in the Affordable Care Act to, you know, give it to the U.S. Preventive Services Task Force. But there's also language very restrictive around telemedicine and things. But again, I think, so yes, I think there's a real appetite for it, and there's going to be much more of an investment.
I think that what we're getting is that because of the intense pressure cooker around cost, which is putting so much downward pressure onto everything, it's forging unusual alliances, and I think that's the point you're getting to. So that what you're seeing now is health plans getting in bed with the delivery system in very intimate ways, whether they become the delivery system themselves, which is happening, or, as you say, health plans partnering with the American Society of Clinical Oncologists or the oncology group of California that says, we will partner together with you if you can demonstrate that you can get your folks in line. So here's quickly the deal here is, if the docs have just gotten about to the point where they are, instead of you saying value-based reimbursement, you've got to demonstrate quality of and cost effectiveness. Instead of them going, we hate you, you suck, we're going to fight you, we're going to argue with you, we're going to sue you, we hate you, to now going, okay, maybe it's inevitable, so how do we make this work? So now you got a bunch of docs that are saying, let's try to make it work. We got something called choosing wisely. Choosing wisely. 15 years after the IOM report on the crossing the quality chasm, which says the system sucks. 3 years after there is a report that says there's $750 billion in waste in the delivery system, the docs come up and say, you know, we probably are ordering things we shouldn't.
Right.
And we're probably doing things we shouldn't do, which is a wonderful thing. By the way, we don't want to put that into performance measures, but we're willing to say we are doing things we should. But at the end of the day, if you believe that the curve is moving in the right directions, with docs are finally saying, okay, we've got to get a handle on the stuff that's a waste. And you can say, okay, now you're actually going to have guidelines for how to use the hepatitis C drug. You're going to have guidelines on something we haven't even talked about yet, which is the new genetic sequencing and all the new genomic panels, which is a whole another scary world. We're going to have guidelines now that'll work, that we will convince if you try to tell doctors to do something and you're not a doc, it is a hard conversation. But docs talking to docs is a beautiful thing. So you now partner and say, docs, good evidence. You're going to have evidence of what works, good guidelines, and we're going to partner with you and implement those guidelines. And if you can show that you've done that, the health plans will give either some sweeteners or will turn off the hammer of medical necessity review, prior authorization, in your shorts for every damn decision you make. You got to call us every other hour of the day, which you hate. We're going to give you a pass because we're trying to move this together. Kumbaya and a wonderful new future.
I think that's critical. When we did a survey of our care centers, they said they reported that half of their time was spent on reimbursement issues, not treating patients, and a quarter of their time. So half of that half was spent on prior authorizations. And what a waste! What a waste!
And I think there's an important point too, because as you're looking at this from an investment community, and certainly the Sovaldi story and others bear this out, and your example in the States is it's very rarely a binary choice of you've gotten through FDA and we're not going to cover it. In a lot of cases, whether it's Medicare or the government or private payers, it's going to be covered. The question is how. And the question is, with what utilization management, or at what specialty tier, or what. And I was interested, there was a report that came out, I think yesterday or today, talking about chronic disease, not focused on providers, that I think it was Care First, which is the local Blue plan in Washington, D.C., is talking about in the next plan year under the Affordable Care Act, providing lower cost sharing or no cost sharing for for drugs that treat chronic illnesses, while they'll retain high deductibles for some others. Now, how they define that, how that gets implemented, but it's interesting in terms of your comment around value. So how it's covered, not just whether, is really important.
And Dean, that's a really important point, because this whole area is completely ripe for innovation, especially with the new legislation out, especially with what people are feeling about cost. I would argue that the private plans are probably far more innovative than the government right now about how they can look at changing these delivery systems and the innovative ways that they're looking at it. Exactly your argument there. And there is a clear continuum of what that's going to look like. And we need people innovating in that space.
So we only have a minute left, and I want to wrap with a rapid fire. Obviously, we've tapped on an awful lot of issues and challenges and things to grapple with and things to mesh together, but I'm going to make you boil it down to one. I'm going to ask it as what's the one thing, but maybe it's what's a important thing that we need in this space to try to bring some of this together and move it forward into the next space. And as the patient representative on the panel, I am remiss in not adding, which we could have talked all day about, that one thing I think we didn't talk much about but is really important is the patient voice in there, and defining clearly what is meaningful and produces a positive outcome in a broadest sense. So, Sean, if I can start with you, and we'll just go down the line.
Yeah, I was going to...
I think we might not have time, but
we'll stay up here.
We'll stay up here.
Yeah. Well, I'm taking the good news, there's a pony in there somewhere kind of attitude about the current system and innovation, but it's all about identifying where there is waste and inefficiency and opportunities to take costs out of the system, and that that's the real opportunity for innovators, is to try to focus on where there is excessive spending. It is a little when Medicare first put in the DRG payment system, the life sciences industry was screaming about how this was going to kill innovation forever. And then the innovators discovered that actually, there's a lot of stuff we can do in the outpatient setting, and there was all this minimally invasive surgery, anything to get from the inpatient setting to the outpatient setting. So I think we just got to focus our creativity on where the business opportunity is, which is taking costs out of the system.
And I would say that we need to continue to intensify the collegial, collaborative conversations across the disciplines to get this done. There are no bad guys in this. There are no bad actors in this. I don't think that any of the people that go do the work that Gilead is doing or others decide, I think I'm going to get up in the morning now and develop a product that's going to rip off the American people and waste money and kill people when we don't have to. I mean, there's nobody that gets up in the morning with that as a business model. On the other hand, there are none of the people that I know that did the work I did in health plans that go, I think we're going to just arbitrarily deny life-saving care to people, and I don't care if people die. Screw them. There's nobody that thinks like that. And I'm sure they're not doctors that wake up in the morning and go, I'm just going to piss away thousands of dollars every day on decisions. This is hard. And I think what I'm just saying is that the effort has got to be in having, and that's why you come to a Millikan Institute and other forums. How do you sort of put your swords down and go, okay, let me try to look at the world through your eyes and your eyes, and then let's talk together and make sure that we figure out how we sort of solve these national problems as a unified whole.
Dean?
We're going to measure quality in healthcare like we measure quality and outcomes in every other industry. It's a little bit more challenging because the consumer's not always the one who's on the hook for paying for it. The third party is. So we're going to measure it. And the measures we have today are going to evolve. And the measures we have today, in a lot of cases, to do that are not adequate. And in part, they're not adequate from the patient perspective because they're not always developed with a patient voice in mind. They're developed based on the outcome and how long someone lives, but not how they live during that period. So I would say as these things get developed, because we're going to measure it, we're going to focus on value, one thing would be that the patient voice, as you do the hard work of getting involved in the measures, and the innovator's voice is really important, that it's not just a single stakeholder.
I would say innovate wisely for your patients. and innovate in a way that makes a difference, which seems a bit of an oxymoron since that's what innovation means, but people are losing, I think, that focus. The other thing I'd leave you with is this is an incredible field, and there's a lot of space for a lot of profit in this field when it's appropriately done. And when you have the patient in mind at the end of the day, and you're not wasting that money.
So first I want to say this is probably the best conversation I've had on this topic. And I've had a lot of them. So it's been the most rational. And I just want to come back to you know, the cost effectiveness and cost conversation we're having. And I think that when we talk about cost effectiveness, it works well for a lot of diseases, particularly ones that we're already treating and maybe treating poorly. And I think, you know, coming back to what I was trying to say, and I said poorly, when we talk about a cure for a disease that was previously uncurable and untreatable, I'm not sure that we can actually have a conversation about reducing costs to the healthcare system, at least not near-term costs, because we're doing something we couldn't do before. We're treating something we couldn't treat before. And so in hepatitis C is a good example. We just weren't treating it before, so there was no cost. We've created a cost. And I think we do need to have a system that thinks about long-term outcomes and long-term savings. Our system doesn't do a good job of that. The people who pay for the hepatitis C treatment today may not be the ones who actually benefit from the reduced cost 10 years from now. And that's a conversation we need to have, and just an open conversation, a comfortable one. And then we also need to think about if we're going to have a debate on hepatitis C, it's going to focus on getting the cost down, getting the cost down. We have to be very careful about the message that sends to other people developing cures, for diseases that we don't treat today, because there are a lot of them, and there's no cost associated with a lot of those diseases today, or the costs are minimized because people just aren't getting access. When we talk a lot about Alzheimer's, a cure for Alzheimer's, what message do we send if we're going to focus on really trying to reduce costs of a cure or not increase any cost to the system, which I think is unrealistic? I think it's a very dangerous message to send. Wow. And from us as a business, what are you telling us? Would do you want more incremental innovation in diseases that are treated poorly, or do you want new breakthroughs, therapies that treat people who couldn't be treated before?
Well, thank you. As the voice for 30,000 people with CF in the room, and certainly personally as somebody who is touched by a lot of diseases in my family, and as we all, I hope we can navigate it through, and I think there's a lot of optimism and hope. Thank you all for a really productive conversation.